Good day, students. We are going into a new venture of the respiratory system after a break of a few days. Respiratory system is a little different from the cardiovascular system, and there are enormous questions, clinical cases, multiple choice questions, as well as viva voce that can be asked from this. I would like you people to kindly follow it. Also, you will be finding that the anatomy and the histology will be unraveled as we proceed from topic to topic. For your satisfaction and mine, the logo has been changed. Variety is the species of life. The topic for today is emphysema, and it is a must-know question, an essay, short note, or an ultra short note. Multiple choice questions, any number can be asked, and viva voce, it will not be spared. So kindly be ready with this. Subdivisions or topics will take us to the question. So the topics are definition, terms, types, pathogenesis, gross, microscopy, clinical presentation, and autopsy findings. For you people only. On one side, I am seeing a mad rush, whereas another side, we are finding one fellow in a cozy comfort. Follow the UQs. IQ is equal to UQ. Definition. Emphysema is defined as a permanent enlargement of the air spaces distal to the terminal bronchiole. Definitions are definitions, no own words. Permanent enlargement of the air spaces distal to the terminal bronchiole. There is another term that we should remember, namely COPD, chronic obstructive pulmonary disease. At one end of it, we find chronic bronchitis. At the other end of the spectrum is emphysema. Bronchial asthma is also included in this. This terminology you people shall and will remember. A schematic diagram showing the respiratory system, the trachea bifurcating into the bronchi, and then the subdivisions of the bronchi, ultimately ending in the bronchioles and alveolar sacs. Please also observe that there are rings of cartilage up to certain division of the bronchi. Beyond the second degree, this is not seen. This diagram I have included mainly for the terminal part. Just see this. The bronchiole, and it has been labeled as terminal, respiratory, then alveoli. Usually we think that terminal is last, but please remember that terminal comes before the respiratory bronchiole. So bronchiole is divided as terminal, respiratory, followed by the alveoli. This is to explain the term COPD again. We find that there are three diseases here: bronchitis, emphysema, and asthma, with a considerable amount of overlap. All of them result in airflow obstruction. And in one region, we find that all the three almost meet. Also note in this diagram that emphysema has been colored pink, whereas chronic bronchitis blue. You will be knowing the reasons of this later on. Please have this in one corner of your mind. A beautiful mnemonic I had picked up from the net. Probably there are young minds that are working on it. Cigarette smoking is primary problem, CIPP, in which C is centrilobular, I is irregular, P is panacenar, and P again is paraseptal, CIPP. On the right side, centrilobular stands for cigarettes, C, irregular stands for inflammatory, I, and panacenar stands for protease inhibitor. Pan A is added indicating alpha-1 antitrypsin deficiency. And paraseptal can result in a pneumothorax. Please remember this mnemonic and read this one. This will definitely stay in your minds. Pathogenesis will form the crux of the answer. A little difficult for undergraduate students, but then follow what I say carefully. The patients are homozygous. Homozygous means they have derived the defect from both the parents for alpha-1 antitrypsin deficiency. And the defect is located in chromosome number 14. Chromosome number 14. Now, if it is going to be from only one parent, the symptoms will not manifest. But if it is going to be from both the parents, you find that the disease manifests and it is PAZZ. Remember this, chromosome 14 alpha-1 antitrypsin deficiency. Another arm of the pathogenesis will be protease antiprotease theory. So please remember these two, which we shall be explaining in the next diagram. A beautiful diagram taken from Robbins and other texts also will be showing. I have simplified it for the sake of the students. The tobacco smoke, it contains nicotine, etc. It leads to vasodilatation and the release of neutrophil. The neutrophil releases an enzyme called neutrophil elastase. And elastase means it is a substance that digests the elastic tissue. So it leads to a tissue damage. So ultimate pathology is the red color here, the tissue damage. There is another defect also. It can be because of alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin, it's supposed to be containing antiproteases. Antiprotease means it nullifies the protease or the elastase. But when there is going to be a defect in the antiprotease, elastase is higher. As a result of which you find there can be a tissue damage. This side shows an alveolar sac which contains a macrophage, and then these cells also will be elaborating the elastase, leading to a tissue damage. I repeat once again, cigarette smoke, neutrophils, elastase leading to a tissue damage. Alpha-1 antitrypsin deficiency leads to inactivation of the antiprotease and increased protease or elastase activity leading to tissue damage. The same can be done by means of the macrophages also. This will form the pathogenesis of emphysema. Please remember this. This includes centriacinar as well as panacenar emphysema. Very important for you people. Basically, there are two types of emphysema. One is a centriacinar, another is a panacenar. Other types are there, we shall be mentioning. Centriacinar, as the name implies, it affects the proximal parts or the central parts of the acini. The surrounding region is normal. Commonly occurs in the upper lobes, associated with smoking, and it occurs in coal workers pneumoconiosis. Pneumoconiosis is an occupational disease and it occurs in that condition. So there are 3 C's that I want to emphasize upon: centriacinar, cigarette smoking, and Kaplan syndrome. Kaplan syndrome associated with coal workers' pneumoconiosis. Kaplan syndrome means there is a pneumoconiosis, along with that there will be a rheumatoid arthritis. This is an important MCQ for you people, please remember. Kaplan syndrome. On the other hand, we have pan-acinar, which affects the entire acinus, more common in the lower lobes and bases, associated with alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. The 2 things. We shall be seeing these again. Okay. Just to bring to you the history of pathology, Gough Wentworth was a person who introduced sectioning of the entire lung. The entire lung has been cut into a tissue section to study the pathology. Look at the pathology of the lung in a case of emphysema. Normally the lungs have got a sharp border and they are not as large as this. In emphysema, the lung is inflated. The borders are rounded. The borders are rounded. And if you were allowed to touch the lung, it will be feathery to feel and pillowy to touch. And because of the loss of elasticity, there can be the impression of the ribs that can be seen in autopsy. Impression of the ribs can be seen in autopsy. Inflated lung, rounded borders, feathery to feel, pillowy to touch, impressions of the ribs. Please remember this. The types of emphysema, I am again explaining. This is a thematic diagram. So, it is a terminal bronchiole, respiratory bronchiole going on, and then the alveolar duct and alveolar sac. But in a case of pan-acinar, the distension starts from the respiratory bronchiole, goes up to the entire acinus. All are distended, that is why it is called pan-acinar. In centriacinar, on the contrary, you find that the central part of the acinus is distended. The proximal part is normal, distal part is normal. So it is called as centriacinar or centrilobular emphysema. Irregular emphysema is, I find that there is a central portion that is affected, part of the distal portion, but then the remaining is normal. So it is irregular. It is neither centriacinar nor pan-acinar. And distal acinar is, it goes to the edge of the lung. So the distal part is affected. It is called also a paraseptal emphysema. There are other types of emphysema. Please remember this. More the types, more the marks. 5 will be a compensatory emphysema. Compensatory emphysema is a compensatory hyperinflation. Whenever part of a lung is affected, there is a collapse, etc. You find that the remaining lung can become distended. It is called compensatory emphysema. Senile emphysema occurs in old age due to loss of elasticity, but the function is not affected. Compensatory emphysema, senile emphysema. Interstitial emphysema. You find that air collects in between the alveolar sacs. This can be because of a fractured rib or children with whooping cough. There can be a rupture of the alveoli, leading to collection of air in the septum. In surgery, a flail chest can be a question for you. That means an interstitial emphysema. Mediastinal emphysema is the collection of air in the mediastinum, and there is a distension like a Walt Disney balloon. It will be quite frightening when you take an X-ray, but it is harmless otherwise. Nine is obstructive inflation. So whenever there is an obstruction to the bronchial artery, you find that there is a ball valve like action. Air enters inside, but it cannot leave. So this can happen in a foreign body or a tumor, leading to hyperinflation. And last 10 is bullous emphysema, seen on the surface. This can happen due to surgical trauma or a damage due to a tubercular scar. So there are 10 types of emphysema. Please remember the types, but the pan-acinar and centri-acinar can be asked as individual questions also. Microscopy, not very difficult. Remember this one. See the picture. This is an emphysema. I am finding that there are a few islands or strands of parenchymal tissue surrounded by sea of air. All the white color is air, the pink color is the parenchyma. So there are islands of parenchyma in a sea of air. This is a normal lung in which you find multiple alveoli, but then here there are only very few with the parenchyma. Centri-acinar, incidentally, you find that the central area of the acinus is affected, surrounded by normal parenchyma. A beautiful thematic diagram, courtesy Radiopedia. You find that in centri-acinar, the central part of the acinus is affected, surrounded by normal parenchyma. Gray color is normal, black color is pathological. Pan-acinar, the entire acinus is affected. The entire acinus is affected in pan-acinar. And in paraseptal, you find air enters the septal spaces, and it is called as a paraseptal emphysema. Centri-acinar, pan-acinar, paraseptal. Then what type is this one? So this is a terminal bronchiole, then the respiratory bronchiole, there are divisions, and then finally you get the alveolar sacs. There is a distension of the entire respiratory bronchiole is getting dilated, alveolar duct, alveolar sac, all are distended. It is a pan-acinar emphysema. For comparison, there is an unaffected alveolus. This diagram will form the key of my entire class. It is a must know, and it is a must draw also. And finally, it is a must explain. Must know, must draw, must explain. So this is the normal terminal bronchiole, respiratory bronchiole, alveolar ducts, and sac. So this is normal. Look at it. Compare it with the pictures below. Here the central part of it is distended. It is called centrilobular or centri-acinar. The proximal part is unaffected, the distal part is normal. Only the central part is affected. It is called centrilobular, associated with cigarette smoking. Pan-acinar or panlobular, you find distension starts from the terminal bronchiole, goes up to the acini. All are distended, hence the term pan-acinar, associated with alpha-1 antitrypsin deficiency. The gross picture, again, the same theme is explained. In a pan-acinar, the entire alveolus is distended. I am finding a honeycombed appearance from outside. Centri-acinar, on the contrary, only the central part of the lobule is affected, distended, whereas it is surrounded by a normal parenchyma. And some black color also, it indicates pneumoconiosis or a defect due to cigarette smoking. Remember the Kaplan syndrome, etc. Paraseptal, it occurs below the surface and then goes into the alveolar septae. It is called as a paraseptal emphysema. Bullous emphysema, on the contrary, it is only on the surface. It can be about 1 to 5 centimeters. It can be due to surgery or it can be due to a tuberculous scar. A nice thematic picture, you must be remembering this. And you can also take this to be a summary of the class. You find, concentrate on the picture alone. The patient is pink, so he is called a pink puffer. Pink puffer. And the lips are showing active action. It is called a purse string breathing. Also, some sternocleidomastoid can be in action. Accessory muscles are in action. There is an increase in the anterior-posterior diameter of the chest, leading to a barrel-shaped chest. Ultimately, there is a carbon dioxide retention. Patient has dyspnea, and when he lies down, it is more severe, called as orthopnea. And respiration is prolonged because all the muscles are ineffective. Has a history of cigarette smoking, and he'll be thin and emaciated. So remember all this. You will have to remember the pink puffer. When I say pink puffer, there is another fellow called the blue bloater. Blue bloater is a little ballooned out person, cyanotic, and it is seen in chronic bronchitis. So remember all these. If I were to summarize, we had seen the definition of emphysema, the terms chronic obstructive pulmonary disease, what is the pathogenesis of emphysema, what is the difference between a centriacinar and a panacinar emphysema, and what are the gross morphological changes, feathery to feel, pillowy to touch, etc. And what can be the microscopic findings and the exact clinical presentation. This is an important question for you in pathology as well as in medicine. Efkaristo is my previous term. Now I am using R.A.T.S. Please find out the meaning and response. Thank you.